Now, the point to that whole thing is that oftentimes in medicine, we think we're looking at the right thing when we're looking at a shadow. And then if we study and try to treat that shadow, we're not going to get very far. This may be a little hard to see, but you'll see it's a graph, and there are two lines that start at 100% and go down to 0. And this represents patients who die from a disease. And this happens to be leukemia in childhood. Back in the days when I was a child, these lines were the typical lines. If a child came in with leukemia, it was a hopeless thing. You could maybe keep them alive with some blood transfusions, with some antibiotics, but ultimately over the course of 6 months to a year, if you had a child in the 50s and early 60s diagnosed with leukemia, that was it. And it was a very hopeless situation. But we as doctors knew that there's got to be some things that we could do. And early on, we began to realize that with advances of treatment and then with certain kind of antivitamins, we knew leukemia depended on a vitamin called folic acid. All of you know about folic acid. It's in leafy green vegetables and all that. And if you starve a leukemia cell of folic acid, they can die. And with that, we were able to extend the life of a patient. But for the most part, you can see in the light blue, for the most part, that's some other advances in therapy over the next 10 years. We could extend the life of a child to 2 years, and every once in a while, there was a child that survived and lived into adulthood. We didn't quite know why. But we began to have hope. And we would talk to parents saying, we have some treatments, we're learning how to do this better every day. I think the chances are that we can have your child have a couple of years of life, and there's a possibility that they could be cured. Now, if you had a 2% or 5% possibility of having your child cured by doing the treatment, would you go for it? Or would you say it's a hopeless thing? Why would I do it? Now what's happening, this is today, with the advances of treatment, and it's because we realized leukemia was not one disease, it's about 6 diseases. And that there's not just one way to treat it, there's 6 ways of treating it. That now we can, by customizing the treatment, we can tell a child's parents that there's a 90 or 95% chance of that child being cured. And one of the great joys of life has been to see children go from a pretty much hopeless situation to who grew up and ended up getting married and having 4 children. So if you think having leukemia keeps you from having children, you'd be wrong. And she called me a few years ago and said, we've named our 3rd child after you. It's a little girl. And I'm thinking, what are you going to name the girl, John? And I said, and they named her Neely after my last name, Neely. And so I go see not so baby Neely anymore. She's almost 3 years old. Now, the point of this whole thing is that Alzheimer's is not, as Dr. Turnpaugh is going to tell you, is not a single disease. There's multiple ways of approaching it. And we are beginning to understand. Are we at the point where we have a 90% cure rate? No. Are we at a point where we are seeing significant numbers of people with early Alzheimer's and even advanced Alzheimer's beginning to show improvement and reversing it? Yes. How many of that's going to be is where we are fervently trying to learn. There's research going on, there's trials going on, there's the events that Dr. Turnpaugh is going to talk about as to how we delineate Alzheimer's disease and how we go about trying to treat it. Because even though it's not 100% cure, we're going to see an extension of hope there. And if you've got, let's say, 10% hope, I'm going to go for it. Okay, so with that, I'd like to have Dr. Turnpaugh come up and talk about Alzheimer's.
Thanks, Dr. Neely. So this is a perfect primer of what we're going to talk about tonight, because we're going to go through a little bit of the history of Alzheimer's and then the hope that we do have. And Suzanne Jones, who's our brilliant massage therapist, she came up with the quote today. She said, "Hope is only false to those who don't see it." So I put it right in here, because that's, if I have a family member who is a little critical because they say there's no hope, there's no hope, there's no hope. And there is hope. There's no hope if you don't see the hope, you don't look for the hope. There's no hope in the cancer patient who says, look, let's look backwards and see that if we look backwards, nobody has survived, but if we look forward, people do, and people can. So a little bit about Alzheimer's. Alzheimer's is the only one of the 10 most common causes of death that has no medication, no help, and no opportunities for success. Out of the top 10, it's the only one that doesn't. It is a disease which causes a gradual fleeting and scares people because they're drifting into this condition where there's no reversal. They gradually lose a sense of themselves. And the fog rolls in and stays there and doesn't lift. There's no hope, there's no drug, there's no cure. But if we look at it from a different point of view, and that point of view is it's more of a syndrome, as Dr. Neely was discussing. It's many different facets. It's not one thing. If it's not one thing, there's not going to be one pill to cure it. It's not a single cause, single cure, single correction. A little bit of a story about the history of Alzheimer's. There it is. I know it's hard to see. We're going to get a bigger screen because I think we're going to make this a series so we can have people continue to educate. So this is just the first one. We want to improve this, improve how it's done. We're going to get a bigger screen and a little different presentation. But in 1901, a patient came to Dr. Aloysius, and she had dementia. The doctor followed her until 1906 when she passed away. When she passed away, he did an autopsy, and he found some strange things in her brain, these beta amyloid plaques and these tangles. And this was in 1906, and he described it. And this was Dr. Alzheimer's, who named the disease in 1906. If he was alive 3 years ago, he would offer the same hope he did in 1901, which was 0. So in over 100 years, we've made 0 advances in a condition which is in the top 10 leading candidates of death. As many people die from Alzheimer's in this country as cancer. If you live to be 85 years old, there's a 50% chance you'll have Alzheimer's. So if you live to be 85 years old, there's a chance you'll either have it or be a caregiver to somebody who does have it. 1 out of every $5 that are spent on Medicare today go to Alzheimer's. The last drug that was approved was in 2003. And current ones are not effective in reversing Alzheimer's. Of the 244 drugs that went to trial, 1 got approved, and it's not that effective. There's nothing that prevents or halts the disease to this day. It's fatal, but worse, before it's fatal, it robs us of our human qualities. It robs us of our life. In 1995, there was a discovery of a gene which helped to isolate risk factors for Alzheimer's, but it didn't lead to any breakthroughs in treatment. So the theory was these beta amyloid plaques in your brain were what caused Alzheimer's. When we think of the beta amyloid plaques, I want you to think of those shadows of the camels, because the beta amyloid plaques are the consequence of the body's response to something, not the cause of the disease. I put a few articles in here not to bore you, but this is what I do for fun. So these gram-negative bacterial molecules are associated with Alzheimer's disease pathology. And what it goes on to say is, what triggers some of these things are spirochetes, oral health, chlamydia, pneumonia, H. pylori, different viruses, cytomegalovirus. All of these things are contributors to Alzheimer's. So how can that be? What's the mechanism of what's going on? In the last 18 months, this was published in 2015, I believe. 2015, yes. There's been reports that show that these bacterial microbes from our gut health plays a huge role in Alzheimer's. Oral health, a large predictor of whether or not you're going to get Alzheimer's. Dr. Ari Vijjani, a friend of mine, he's considered the world's foremost immunologist, put this risk factor together. So abnormal gut microbiome, toxic exposure to different things, infections, certain vitamins, cholesterol issues, hormone issues, and ability to get blood flow to your brain. This slide I took from him, and it just goes through the steps of how the root cause of Alzheimer's may be in the gut and gut inflammation. So one of the keys you want to look for, that's a depiction, this is a depiction of Dr. Vijjani. You have to find out what's going on. So we need to detect what's going on. And then if there's a pathogen, we need to remove it. And then we need to repair the damage that was done. The current model is, let's repair or remove the beta amyloid plaques. If we remove the beta amyloid plaques and don't remove the triggers or the lifestyle that got us there, it's going to come right back. So the efforts have been in those 244 failed drug trials, remove the plaques, remove the plaques, remove the plaques. Nobody's asking, what's the root cause? What's the root cause? What's the root cause? So some of the work that we do is based on Dr. Dale Bredesen's book. If you don't have Dr. Bredesen's book, I think it's a key book to get. So Dr. Bredesen spent 20 years of his life looking for the magic drug, one of the world's foremost researchers on Alzheimer's disease. We're thankful that his wife was a functional medicine doctor who said, you're not going to find a drug. You're not going to find a drug. And he said, I'm a brilliant neuroscientist. I'm going to find the drug. And when he put all the syndromes together, he says, I'm not going to find the drug because there won't be a drug. But I'm married to a brilliant functional medicine doctor who said I need to look at different things that include causes of inflammation, oral health, infections, diet and lifestyle, stress, and yes, there are some underlying risk factors. So this is going to be difficult to see, but a lot of what I'm going to present is going to be based, at least in the first series here, is going to be based on Dr. Bredesen's work because it's very well documented and everybody can go out and buy the book, so you can reference it yourself and see yourself what he's talking about. So he breaks the Alzheimer's down into 3 or 4 different categories. But in 2014, he published a study that showed the reversal of cognitive decline. So 10 people were in the study. 9 of them had Alzheimer's or pre-Alzheimer's conditions. All 10 of them completely reversed. This was not a drug. This was not a single modality. This was not, here's the pill to fix your problem. 3 additional studies over the next 3 years confirmed the same type of results. And when he tried to get funding for his study, they said, you're manipulating more than one thing, we can't do that. You're doing more than one variable, we can't do that. And this is when the epiphany went off in his head and said, we're never going to solve this problem with the way we think about healthcare today. It's never going to be solved if we look for the drug. If we look for the single way to fix this. He also goes on to make a pretty strong statement. No one should die from Alzheimer's. Yet it's one of the top 10 leading causes of death with no hope. Yet he says nobody should die from it. But 45 million Americans are expected to die from Alzheimer's. As he goes on to say, it can't be a single drug approach. There are hundreds of drugs that have shown to remove the amyloid plaques, and 0 have shown to halt or reverse the disease. This is, of course, why there's so much skepticism. If the most brilliant minds in medicine cannot come up with a drug, what makes you think that diet, lifestyle, and looking at it from 37 different ways is going to make a difference? But there's just over 200 documented recoveries from Alzheimer's. 2 are in our office. Over 200 have fully recovered. The treatment must identify the contributors, remove the contributors, help the body build itself back up, and then remove the amyloid and rebuild the synapses so they come back. It has to be a very individualized program. But all of the factors need to be addressed. You can't put 3 legs underneath a table and expect it to stand. It's not easy. The alternative is worse. The program needs to identify many contributors, but it's not going to be a single therapy. And we are just learning about this. And we are fighting the system which says it has to be a single drug. So we have to go against the grain with no research money, without IRBs, which we can do, to say, let's check this program against a single drug program, against no program. That kind of makes sense, but they say we can't do that. We can't do that. It's extremely complex. The cause of cognitive decline, if it was easy, we wouldn't be sitting here. We would have solved it by now. Dr. Alzheimer's wouldn't have had to wait over 100 years for somebody to try and discover what the mechanism of action was. Dr. Bredesen has identified many things, and so have others, but I'm sticking to the solid ground for this one. We can branch out in the future, because I know firsthand from my family, there's a lot of skepticism, there's a lot of critics, so let's stick to what has been researched. There are many puzzles, there are many pieces. Many of them can be missing. It's not a single approach. We've broken Alzheimer's down into 3, possibly 4 subgroups. Of those, a minimum of 36 to 42 variables. Of those, combinations and permutations of each one. So what drug is going to fix that? Dementia. One is Alzheimer's, and it's the most common, and it's defined by the plaques and tangles that we see. There's frontotemporal dementia. There's Lewy body dementia, which is about 1 to every 5 Alzheimer's patients. Subjective cognitive decline, I'm just going to go through some of this because some of you may have heard it. Subjective cognitive decline, you'll test negative for cognitive decline on all your standardized tests. However, you know you're not as sharp as you used to be. It's very subjective. So it's not where you were, but you're not impaired enough to test positive on a test. Then there's mild cognitive decline, which progresses from subjective cognitive decline. The mild cognitive decline, you'll have issues with memory, organization, speaking, calculating, planning, talking, but you're able to function still. You're able to get up, shower, dress yourself, but you now are in the mild state, which it may be documented. This may take 15 years or so to go from the subjective to the mild cognitive decline. The mild cognitive decline is a precursor to Alzheimer's, and within a few years, you can drift off into Alzheimer's. PET scans can show the presence of these tangles and plaques, but remember, they're not the cause, they're the result of. The onset can take 20 years. The early excuses are what we all say. I had a brain cramp, I'm getting older, I have brain fog, I had a senior moment, all the things we say. Now, all of these things do not lead to Alzheimer's, but all of the Alzheimer's patients once had these statements to say. So it's not necessarily leaning into Alzheimer's. Some of the signs: decreased processing, driving anxiety, forgetting your to-do list, mixing up words, sleep disruption, no boost from caffeine anymore, mental fatigue at the end of the day or 2:30 early in the day, a decrease in pleasure from reading because it's hard to stay with the story. You read, you forgot what you read. Who was that character? You turn 2 pages back because you don't remember what you read. So how do we get Alzheimer's? Well, we work late. We stress over the day. We eat a sugary breakfast of donuts, bagels, cereals, juice, milk, coffee, which drives our insulin. We eat gluten, we eat dairy, we eat highly processed foods. So then we take antacids. The antacids decrease our stomach acid. By decreasing our stomach acid, we decrease nutritional absorption of zinc and magnesium, B12, iron. We decrease the ability to make neurotransmitters in our brain. And then we take statins to lower our cholesterol from our poor diet, which facilitate brain atrophy. So a typical scenario: you eat late at night and you snack because you worked all day. You get home late, you eat late. This keeps your insulin levels high when you go to bed. You wake up, you eat breakfast. So you really didn't have a break from eating because you ate late, kept your insulin high, and then you ate breakfast. So these breaks in eating give your brain the possibility to clean up the debris of those amyloid plaques that you made throughout the day of high stress. So this breaking and eating, or breakfast breaks your fast, but if you're eating all the time or eating late, if you ate at 9:30, 10 o'clock, 10:30, and then get up and eat a sugary breakfast, you're fueling the problem. If you take the breaks, you'll give your body the ability to clean up some of that debris that forms. So intermittent fasting or taking a break from eating is very helpful. Then you run to work, you have high stress, you're in a high stress job, so you're not exercising. Then you eat fried foods or fast foods, corn and grain. You eat meats, the meats are not healthy, they're grain-fed meats. Then you wash it down with some kind of soda, and then you lose your sense of socialization because you're too busy and too tired to socialize with friends. Maybe at the end of the night you're stressed, so you have some wine, a glass of wine or a cocktail. And then this leads to poor oral hygiene. And then you go to bed after you've eaten late, and you rinse and repeat and do it all over again. So what do we call this? We call this the standard American diet with the standard American lifestyle. Is it any wonder? Is it any wonder we develop Alzheimer's? Then we expose ourselves to toxins, inflammation, loss of nutrients and hormones over time, and we'll talk about the different categories of Alzheimer's. Infection from Lyme disease, all our viruses, bacteria, fungi, parasites, biotoxins, mold. Non-infectious stressors, high sugar diets, unhealthy fats, lack of sleep, lack of exercise, lack of proper nutrition. When we take these patients post-mortem and look at their brains under the microscope, they pretty much all have viruses, bacteria, mold. They don't have the ability to fend off these things. So we want to talk about the response. Once the brain's invaded, it has a selective immune system. And one of the ways it triggers its immune system is to make beta amyloid plaques. It is a response to the stress that's going on. And stress can be an infection or a fight with your spouse. Stress can be working late or eating a high sugar food. Stress can be a virus or it can be Lyme disease. It can be any or all of the above. And when your immune system goes down, how well do you tolerate stress? Less or less? So if you get an infection, you're more likely to fight with your spouse and get a poor night's sleep and crave sugar. Well, we have barriers in our system. We have a blood-brain barrier, we have a gut barrier, a lung barrier. Everybody recognizes their skin barrier, right? So these are barriers that we have. When we have a breach in the barrier in the gut, all those bacteria we talked about earlier, they cross out of the gut and go into our body and trigger an immune response. Sugar is like a poison or fire. It increases insulin, and insulin increases the possibility of Alzheimer's. I'll touch briefly, not to bore too many people, but one of the things that happens is we make insulin, and we also make this thing that degrades insulin, an insulin degrading enzyme, okay? So we make insulin, but we don't want it to last forever, then we make an insulin degrading enzyme. It breaks down insulin. But if we have a whole ton of insulin, we use all of our insulin degrading enzyme to break down insulin. But insulin degrading enzyme has another effect on the body. It degrades beta amyloid plaques. So let's not use it all up for sugar. Let's use some of it to keep our brains healthy. So high sugar drives this condition because of the insulin. Hormones and nutrients. Your testosterone, estrogen, vitamin D, folate, thyroid hormone, progesterone, pregnenolone, DHEA, insulin, etc. All of our hormones. So it's not a single, hey, let's just run that Alzheimer's test on you. It's let's run that Alzheimer's cascade on you. Let's run the whole system on you. In 2016, a study was presented where 90-year-olds with no dementia were studied. All of them had beta amyloid plaques, all of them. And all of them also had love and appreciation and were continuing to learn. So beta amyloid plaques are not the problem. It's a common story. So if we use the same analogy, I would say blue lights cause accidents. You know how I know that? Because every time I see an accident, I see the blue lights of a police car. And in fact, the worse the accident, the more the blue lights I see. So the blue lights, the more blue lights there are, the worse the accident's going to be. Blue lights cause accidents, and more blue lights cause worse accidents. And if it's real bad, I see blue lights and red lights because the ambulance is there in the fire truck. The same analogy is made for rats cause dumps. Because every time there's rats, every time I see a dump, there's rats. And the more rats there are, the bigger the dump. It's the wrong way to look at it. It's the wrong paradigm. So the three subcategories of Alzheimer's are type 1, type 2, and type 3. 1 is hot, 2 is cold, 3 is vile. Hot is inflammation. So in type 1, we want to look at certain things. Now we're going to get into some genes. Now genes do not cause disease. Genes predispose us to disease. An example I like to say is, if you're an albino or very fair-skinned, you do not have the gene for skin cancer. You have an increased probability to get skin cancer, and you probably shouldn't go out in the sun all day long. So genes do not determine disease for the most part. There are a few exceptions. So when we talk about genes, there's the APOE gene. The APOE4 gene is the strongest, most aggressive of the three. There's a 2, a 3, and a 4. 4 is the most aggressive. It's the strongest fighter. So if the immune system in the brain releases beta amyloid plaque, and 4 is the gene that's the strongest fighter, it makes sense that that's the one that's going to cause the strongest response. So the 3 gene is what most people in America have. It carries a 9% increased risk factor. If you have 1, 4, and 1, 3, so you get 1 from mom, 1 from dad. If you have 1, 4, and 1, 3, your risk goes up to 30%, which is 25% of Americans. If you have 4, a 4, and a 4, that's about 7 million Americans. It's between a 50 and a 70% probability of Alzheimer's. It starts with the loss to store new information, even though all your previous functions are there. So it's sometimes hard to see because you remember your name, you remember your children, you're just not learning. You're not learning new material. And the symptoms often start in your late 40s and early 50s. What I'll be too scientific is you'll start to degrade your hippocampus. So that's an area of your brain which is critical to disseminate learning. And the other areas of your brain, your temporal lobe and your parietal lobe, when we look at them, they use less sugar. They're burning less sugar, so they're less active. So they don't atrophy per se, but they're not working. They're just sitting there doing nothing dormant. So there are some labs, and it's really small, but we'll talk about them later. They're inflammatory markers, but it's not the one marker. So now we're talking about a gene in combination with 7 markers, in combination with a lifestyle. So it's not a simple answer. Another journal article, it's just so tiny. Lipopolysaccharide-induced neuroinflammation is associated with Alzheimer's. It's a fancy way to say there is an immune activation which can lead to Alzheimer's, which may start in your gut. Gut health is important. Type 2 is atrophic or cold. This is where the ApoE genes carry little risk. They carry little risk and increase it. It occurs later in life, a little bit later in life. It has a similar presentation with the loss of the ability to learn new information. The inflammatory markers may be negative or positive, but the support for the brain starts to fall. And in this case, we see hormones like testosterone and estrogen and progesterone and vitamin D and adrenal hormones and thyroid play a role. So now our list of things we need to look just expanded by 3. Type 2 responds less than type 1, and type 1 responds the quickest. But type 1 is the earliest. So the earlier we start to look for these things, the quicker we can start to reverse them. And the ones that present the earliest are the ones that respond the best. So if you're 92 and you develop Alzheimer's, it's different than being 52 and developing Alzheimer's. And the 52-year-old that develops Alzheimer's has the best probability to reverse their Alzheimer's. But not if you don't look for it. Type 1.5 is very common now. It's called type 3 diabetes as well. It's when you have elevated blood sugar, and these blood sugars disrupt the proteins, and then what happens is you're called type 1.5. It's a combination of 1 and 2. So lo and behold, what type do you have? I have a mixed match of all kinds. I have a mud of Alzheimer's. I have 1, 2, and 3. Those are things that can happen. Type 3 is the vial. Vial is more common if you have the APO3 gene, right? Because you have less defense. Remember, 4 is that real strong defender. 3 is less defense. This is the one where there's no family member. Nobody in my family had it, or they developed it after the age of 80. Symptoms can begin in the 40s to the 80s, and usually after a great degree of stress. It begins with cognitive difficulty in speech, numbers and poor recognition. You lose recent and old memories, so this presents differently. It's more rapid, it's more significant, it's more severe, it's more lifestyle driven, and it's not genetically predetermined. MRIs can show changes in how the fluid moves in the brain. This responds the worst. But this is the one that we can see coming, because this is usually triggered by lifestyle in a high stress environment. It's important to regulate things like hormones and thyroid and things that help our bodies recover, and inflammation. It causes global atrophy of the brain, not just a particular area, so the whole brain starts to shrink and atrophy. It's most common with things like heavy metals, exposures to toxins, and biotoxins like mold and aflatoxins, which are in 70% of our commercial grains. So should we remove the beta amyloid? Remember what beta amyloid does. It protects our brain cells. It protects our brain cells. The most aggressive ones are the... So if all we do is take away the protective fence, but we don't go after the triggers, the infections, the bacteria, the toxins, the stress, and we take away the defense mechanism, what happens? The brain degrades faster. So the medications that are seeking to remove the plaques are removing barriers to protect the brain. So a little pictorial. Everybody has these amyloid precursors coming out of their cell membrane. And then they can be cut at different areas. They can be cut here, they can be cut here. If they're cut here and we release this beta amyloid, they kind of stack together. They have like stickiness to the outside of them, and they'll get stuck together and they'll form these tangles. So here we see how they're cut. They're cut at a defensive posture. They're cut where it would be protective to the brain. Through the enzymes, the beta amyloid is released. It congregates together and forms the beta amyloid plaque. So do we want to remove those? Yes, we do. But after what? After we get rid of the offending agent. After we change the situation which allowed it to come in the first place. And there's the progression. We see the molecule, the APP molecule. We cut it off with the enzymes, and then we develop the plaque. So again, we're going to work on making this bigger, but instead of a colonoscopy, maybe we should have a cognoscopy. So what's a cognoscopy? A colonoscopy is we just look at the colon. A cognoscopy would be, let's look at factors that play a role in cognition, which include your gene, inflammation, infection, inflammation, blood sugar, hormones, toxic metals, ability of the immune system to respond, the health of your gut, the health of your blood-brain barrier, the health of your waist, which is BMI, pre-diabetic, volumetrics where you can take MRIs and see if something's going on, looking at B vitamins. So we want to have a targeted approach, not a single monotherapy approach. It is less likely for someone to say, let me go to the doctor because I think I have Alzheimer's, because when they go to the doctor, what are they told? If you have it, there's nothing you can do. It's not a good sentence. It's not a good day. That's going to add stress to your life. Stress to your life after you're told you have something which is a progressive, irreversible neurologic disease advances the progressive, irreversible neurologic disease. So why would you go to have someone give you the bad news? So if we don't offer hope, we're not even going to identify this. We're not even going to look for it. We're not even going to try to reverse it because there's nothing that can be done. Then we have a fear of losing our independence. So once we're told this, it's when are you going to take my license? When am I going to have a place I don't want to live? When is the next shoe going to fall? There's not a good outcome. So we can consider certain therapies. Certain therapies that have shown promise are simple things like craniosacral therapy, hyperbaric oxygen therapy, exercise, lifestyle, weight management. These are things that are very simple to do. Then we get into some of the more complicated ones, which would require somebody working with you to identify some risk factors. How are your sugars? So I lecture to a lot of physicians around the country, and I was in San Francisco three weeks ago, and I said, how many people know their blood pressure? Most people raised their hand. How many people know their cholesterol? Most people raised their hand. I said, how many people know their A1C or their vitamin D? And the hands didn't go up. And I said, these are more appropriate risk factors than the two previous. So what is your sugars? What's your fasting sugar? What's your fasting insulin? Your sugar should be less than 15 grams a day for many people. That's what most people consume in their snack before breakfast. They triple that in their soda. It's a lifestyle. The standard American diet and the standard American lifestyle is primed for Alzheimer's. So if we have sugar, if our fasting insulin is above 4.5, so I've been doing this about 25 years. When I started, normal fasting insulin was 11 or less. Then it went from 3 to 17. Now it's 3 to 21. And the numbers go up and up and up because everybody is pushing the envelope. And so if you don't eat sugar, you shouldn't make insulin to get the sugar out of your system, so it should be very low. Progressing towards a type 2 diabetic situation, fatty liver, metabolic syndrome. A simple test, it costs a lot of money. It's called hip to waist ratio. You take a tape measure, you put it around your hips, you put it around your waist. If you're a woman, it should be 0.8 to 1. If you're a man, it should be 1 to 1. If it's greater than that, it increases your risk of all mortality. All. The insulin needs, I talked about this, the insulin needs to be degraded. So if you release too much insulin because you eat too much sugar, you need to release your insulin degrading enzyme, which will degrade the insulin, but won't degrade the beta amyloid plaques. So your fasting insulin should be less than 4.5. Your fasting blood sugar should be less than 90. I tell everybody 80 to 89. 85 is perfect for me. So normals, though, are 65 to 100. If your blood sugar is 64, you have medical hypoglycemia. If your blood sugar is 65, it's normal. No, it's not. If your blood sugar is 99, it's normal. If it's 100, you're pre-diabetic. No, it's not. These are functional ranges that we want to get into. And your hemoglobin A1C should be less than 5.8. Now let me explain what hemoglobin A1C, most diabetics may know what it is, or if you watch TV and all the drug commercials tell you what it is, you might know what it is. But what it really is it's called a glycosylated end product. To me, I'm a simpleton. When you take an onion and you put it in the pan and you cook it and it caramelizes and it gets sweet, that's glycosylation, right? That's what's happening to your red blood cells over time. The reason we can measure it is because a red blood cell lives about 120 days. So it has a certain rate of how much sugar kind of gets stuck to it, which is okay because we're going to make new ones. But our brain, we don't get new brains. So anytime, if you're familiar with diabetics, they say a well-controlled diabetic has a hemoglobin A1C below 7. Okay? Why is that? Because above 7, they're caramelizing their brain. You're actually taking that onion and cooking it and caramelizing it. And if you take that onion out, how long does it take to get bitter and hard again? Oh, it never does? Neither does your brain. Yes? The greater than sign is backwards. Should be less than. Good catch. That's my brilliant wife. Oh, Dr. Brown. I even had it proofread, but that's not a misspelled word, so. CRP. CRP should be less than 0.9. CRP goes up due to things like leaky gut, gluten, sugar, trans fats, toxins, stress. If you kick me in the shins, my CRP is going to go up. If you get the flu, your CRP is going to go up. If you have a chronic viral infection, your CRP is going to go up. It's an independent risk factor. Ratio of albumin to globulin, which is run on just about everybody because it's a $3 test. It's a comprehensive metabolic panel. If that ratio is at least 1.8, if your albumin is above 4.5, these are things we're looking for. If you do your omega-6 to omega-3 ratio, it should be less than 3, but greater than 0.5. And if you run some more specific tests, interleukin-6 and TNF-alpha, there are certain numbers for you too. Vitamin D. Vitamin D is critical. There's 4 things every case in healthcare fail. One is low vitamin D, one is low thyroid, one is anemia, and one is poor blood sugar. If you don't solve those 4 problems, it doesn't matter what you do next because they affect every cell in the body. If you're not getting blood to a cell, who cares? If your blood sugar is up and down and up and down, it affects every cell in your body. And vitamin D turns on over 900 processes in your body, including it's essential for brain synapses and neurotransmitter function. We say vitamin D is okay if it's 30. If you're below 50, you're at risk for every autoimmune disease. If you're below 40, you're at risk for cancer. If you're below 30, you're at risk for bone loss. Optimal's 80, should never be below 30. Thyroid hormones, some say they're controversial. I say they're not. It's information. We want to check your thyroid hormones, your adrenal hormones, your sex hormones. The thyroid controls metabolism of every cell in your body. It controls your temperature, your heart rate, sleep issues, cognitive impairment. And when you get your thyroid measured, you shouldn't just get your TSH measured. It's your TSH, your free T4, your total T4, your free T3, your total T3, your reverse T3, your thyroid peroxidase, and your thyroglobulin antibodies. It should be standard. It's not, because we typically medicate based on a TSH number, but I'm not worried about being hypothyroid tomorrow. I'm worried about the 15 or 20 years it takes for me to slip into Alzheimer's. So how about you run those other 6 tests for me, doc? It's not that hard. I put the reference ranges for thyroid in here. Everybody has different ranges. So, but your free T3 lasts about an hour. That's your 1-day half-life. And it should be between 3 and 4, some say higher, 3. I put the numbers up here that Bredesen uses. I don't always agree with him. I've met him, we've had conversation. It's a professional, we're splitting hairs, the rest of the world is dealing with pathology. So TSH between 0.4 and 2.0. Your free T4 lasts 6 days, that's your longer lasting one. 1.3 to 1.8. Your reverse T3, which shuts your thyroid down, you want it less than 20. And you want your free T3 ratio to your times 100 to your RT3 about 20. So 20% of it should be there. Estrogen and progesterone. Every man over the age of 20 should get his testosterone checked. How do we know what your levels are if they're low or high if we don't have a baseline? We'll get a baseline EKG, we'll get a baseline a lot of things. We should get a baseline of hormone. So if your testosterone is typically 850 and it drops to 350, and we don't know that, we might say 350 is normal. But if you've dropped 50%, that's a big deal. Guess where the largest population of testosterone receptors are in a man's body? His brain, the frontal lobe of his brain. The first sign of low testosterone is cognitive decline. Oh, I skipped here. Estrogen cleaves the APP and prevents dementia. Low estrogen may double the risk of dementia. So should we check it? Well, I don't have hot flashes, doc. I cruise through menopause. I think I'm good. Okay, let's just let you linger out there with the risks of Alzheimer's. Let's not do that. Let's check your progesterone. Let's check your ratios. Let's check your testosterone. Men with low testosterone, it increases their risk of Alzheimer's. It's a simple test. We check it free, we check it total. Optimal ranges are between 500 and 1,000, and free is 6.5 to 15. Stress hormones, the adrenal hormones, the stress hormones. Short-term stress is okay. It's not that we shouldn't have stress. We're built for stress. We can handle stress. All of the chronic problems that we suffer with today are due to a lack of resolution of a chronic problem. There's a book from the 70s, Why Don't Zebras Get Ulcers? Zebras are chased by lions, so if stress caused ulcers, you think every zebra would have one. The thing is, they get stressed, they run away, they survive, or they don't. The ones that survive are okay. They had their fight or flight, they got over it, they recovered. If you're running from a tiger every day of your life from the past 20 years, that's abnormal stress. That's called the standard American lifestyle. Okay? So we want your AM cortisol between 10 to 18. Your DHEAS is a little bit different for men and women, a little bit higher in men than women. And your pregnenolone, which very few people should be between 50 and 100. It's neuroprotective. It supports memory. Should I look for that? Maybe. Yeah. Pregnenolone, simple, cheap, easy to support. Supports, it's the precursor to all of our adrenal hormones, all of them. Heavy metals can get checked. All metals, actually. We look for zinc. Low zinc is an independent risk factor for Alzheimer's. Zinc competes with copper, so it's important to know how much copper you have and how much zinc you have. Zinc is critical for insulin synthesis, which is important so I don't have too much sugar floating around, so I don't caramelize my brain. A quarter of our population is zinc deficient. That's not an expensive thing to do. Copper and zinc compete. Your free copper has certain ranges and your zinc has certain ranges. It's important to check these things. It's not, oh, I ran that test for Alzheimer's, did you? Because if you didn't take 18 tubes of blood out of me, you probably didn't check me for the risk factors. Glutathione. Glutathione is called the body's bodyguard. It protects us from things like cancer and heavy metals and autoimmune disease and anything. It protects us against what I call I don't feel gooditis, right? It's anything. So glutathione is very, very important. It pulls out heavy metals. It quenches free radicals. It supports all the aspects of our body. It's called the body's bodyguard, and it can be measured. We work with Quest and LabCorp. We come up with these tests, and they say, you're one of the only people that run these tests. And I say, everybody should be running these tests. We want to look for heavy metals like mercury, cadmium, arsenic. And we want to have, we want to have tolerance to these metals. So if I checked everybody in this room, how many people are going to have mercury in their system? I'll answer that for you, all of you. But all of us don't have a. So I tell a story that was told to me by Jeffrey Bland. In year 2000, there was a famous case in Louisiana. Husband and a wife were building an outdoor deck of pressure-treated lumber. Pressure-treated lumber at the time used copper chromated arsenic, CCA. The wife gets sick, goes to the hospital. At her third hospital, they recognize she had arsenic poisoning, and they put the husband as the chief suspect. The reason I remembered is the wife says, we live in Louisiana. If my husband wanted me dead, he'd just shoot me. So he's the suspect until they check his levels. His levels of arsenic were higher than hers. They were dealing with the pressure-treated lumber. She had the arsenic in her. He had the arsenic in him. His glutathione levels were higher than hers, so he was able to tolerate the toxic metals where she wasn't. So all of us are exposed to these things, but how well can we tolerate them? Sleep. Sleep, I think, is the number 3 or 4 reason today. And in the top 3 is gastrointestinal. So we've talked about how stomach health is an issue. Sleep and stress is an issue, right? So sleep. During sleep, we initiate autophagy, which means self-eating, which means we remove beta amyloid plaques in the brain because we don't have the defense. We can kill the bugs. We can get rid of the beta amyloid plaques. Sleep reduces amyloid for that reason. Sensitivity. Sleep increases growth hormone, which is used for repair. And sleep apnea is a constant interruption of sleep, and it may lead to Alzheimer's. It's a risk factor. And then there are other markers. Interestingly enough, we want our cholesterol. If it's too high, we can get plaques in our arteries. If we get plaques in our arteries, we can reduce blood flow to our brain, which can lead to brain atrophy. If our cholesterol is below 150, we don't have enough to support brain health. So if I'm a cardiologist, I want your cholesterol at 0 so you don't die of a heart attack, because I don't care if you get Alzheimer's. Because my goal is to keep you from dying of heart disease. If you die of anything else, I win. The difference is you're a human body, not a heart or a brain. So you want to be the whole bodyologist. So we want your cholesterol above 150 but below 200. And we want your healthy cholesterol, your LDL particle size, between 700 and 1,000. So we don't want you to have cholesterol of 180 and all of it be that LDL cholesterol. We want healthy ratios of cholesterol. We want your B1 healthy. We want your vitamin E healthy. We want your leaky gut evaluated, your blood-brain barrier evaluated, your gluten sensitivity evaluated, your body mass index evaluated. And there's a test. It's expensive. No, it's free and it's online, and it takes about 10 minutes. The MOCA test, the Montreal Cognitive Assessment Test. It's available online. It takes about 10 minutes. This is a test you can do. There's 3 different versions, so you can't memorize the test each time you take it, and it helps to determine where you're at. So again, hope is only false to those who don't see it. If there is Fog, let today be the first day that we lift the fog. Let's lift the fog and address the problem that's killing us with no hope. So I hope this was informative, and I hope that we can continue these and increase our dialogue and turn it into a series so the community can become more educated, more empowered. We have less caregivers because we have less sufferers, and we can empower the healthcare community to move towards a multifaceted approach instead of a single approach. It's more complicated for the physician, but the physician works for you. So that's my encouragement.